Welcome to Medscape. I'm Dr. Andrew Wilner, and today my guest is Dr. Jean Sung. Dr. Sung is the senior author of a recent paper that appeared in the Journal of the American Medical Association on a new approach, a refined approach to determine brain death. It's called the World Brain Death Project. Welcome, Dr. Sung.
Thank you.
Now, Dr. Sung, you are, is it the president of the Neurocritical Care Society? Is that one of your one of your side jobs? Um,
I'm the ex-president.
the ex-president. Okay, but it's your interest in neurocritical care, right? That sort of exposed you to a lot of these situations where is the patient brain dead or is not brain dead? And was that part of the origin of how you got involved in this project?
Yes, yes, very much so.
And so World Brain Death Project, that sounds pretty ambitious.
Well, at the time, it seemed uh, easier easier than it ended up being. So it ended up being a whole 5-year project, but it was definitely a project of what we felt was of great importance.
And I'll jump right to the bottom line. What did you guys conclude?
Well, there are two main goals for this project. One was to try to minimize the differences of the determination of brain death that was occurring worldwide. Uh, and two was to make sort of a foundation, or really ended up being kind of a textbook of what we know about brain death at this point in time, and to have this as a resource for anybody who had questions about brain death, or about or any of the features of brain death. And then even, in fact, we had the one chapter devoted to what we don't know about brain death and possible research projects that should be done to help us expand the knowledge base of what brain death is and how to do it.
Can you give me an example? In other words, when I do a brain death examination, I follow the checklist and the AAN. And one of my colleagues in Paris is doing a brain death examination. Is he doing something different?
Well, so there are a number of papers that have been published showing the differences in guidelines that different countries use, or even here in the United States, that different states will have different guidelines of how to determine brain death. Some of the most common differences that we've seen are the number of examinations that need to be done. So some countries require, or states require, just one examiner and one exam. Some require two. Some even require three. Some guidelines require ancillary tests. Most in the US only require the clinical examination, and you don't need an ancillary test. So those are a couple of the more common differences that we see.
I'd like to emphasize that point. In the world brain death sort of consensus, only one exam is necessary that fulfills all of the clinical criteria. Only one examiner is necessary to do that careful examination. Of course, all of the confounders like hypothermia and sedation, those things have to be controlled for.
Yes.
But ancillary tests like a flow study on MRI or a SPECT or an angiogram, those are not required. Is that all correct?
That's what our recommendations are. That, again, we have ample evidence from the literature that shows the clinical examination is still excellent at determining brain death. Again, as you've mentioned, as long as there are no confounders, and we have a uh, very specific list. We try to be as thorough as possible about all the different confounders that could influence the examination. So making sure that those are not present, as well, and making sure that exactly how to do the examination, etc. So to be very, again, as clear as possible. is what our recommendations are. Certainly, different countries will still probably do some things differently. And that's not completely unexpected, but we hope that we can minimize some of these differences, as well as quite a number of countries don't actually have brain death protocols or guidelines. And so hopefully they can use this to help develop their own and start that whole process.
Now, I'm going to challenge you a little bit and ask you, well, why is it so important? We have patients who are so sick, massive intracranial lesions, and you examine them, and I don't know, maybe they're breathing a little bit, or they have a pupillary reflex, but that's it. They're not clinically brain dead, but when we talk with the family or it's about withdrawing care, it's pretty obvious the person is not going to recover.
Yeah.
So why do we have to be so specific with that this patient is brain dead? When is that important?
Well, certainly to help the family deal with someone who's passed away, and to determine, for many both ethical and legal reasons, to know if someone's died or not is certainly important. And so this is one of the ways to determine if someone's died. But also, certainly, there is now the possibility of organ donation. And so certainly we don't take organs from living people, unless um, uh,
Unless they volunteer.
unless they volunteer, right,
Volunteer,
right,
right.
unless they volunteer that. But in general, so if someone's passed away, and to determine if someone has passed away, can then allow that process to happen as well.
How much has the transplant kind of I hate to use the word business, but the fact that we're doing transplants all over the country and that there's a shortage of organs,
Yes.
and so there is a pressure when organs may become available. How much of that has driven the need to sort of be clear about, dead or not dead? Was that part of this, or is that a completely separate issue?
Well, certainly the two ideas are linked now. However, it should be, first and foremost, it should be um, clear that, again, the history of the recognition of brain death came about separately from organ donation and transplantation. So it really came from the development of CPR and mechanical ventilators and cardiac resuscitation, that we could again get people's hearts started again, and they could get their breathing controlled with ventilators. But realizing that these people never woke up, and they all basically were dead. And so, and that often their bodies would start decomposing. This was in the 50s. And so this was a phenomenon that was recognized, not for, again, it had nothing to do with organ donation. It's just that they saw these these people who basically had died and their bodies were decomposing in the ICUs. And so then the idea that these people had actually passed away, and the term brain death came about. Later, as organ donation became more and more common, it became clear that these patients would actually could become good organ donors as well. And so they are now linked to each other, uh, but the whole, again, determination of this whole World Brain Death Project was not uh, due to anything to do with organ donation or transplantation.
Yeah, I think that's a really important observation that, there's this feeling while you're pulling the plug, you're killing the patient. But these patients are already dead. And even if you continue to support them, say, well, we'll just, give them fluids and we'll keep the ventilator going and suction them now and then. We can even give them nutrition. But if they are brain dead, they will not survive for an extended period of time. Is that
Correct.
correct?
That's correct. And so we're, again, better and better at actually taking care of the body, for better or worse. So we know more about physiology. We can give many different kinds of new drugs and hormones and everything to supplement whatever the body needs. And so we can keep the body going for quite some time. But the patient's really has died. And so to give some finality for the family to understand is the reason for doing brain death. And then also, that's really quite, it's unethical to keep a dead person, uh, you know, attached to all of these things and keeping the body going for no real meaningful reason.
Now, there was one kind of caveat in the paper about normally it's one exam and one examiner. But then I saw, in the fine print at the bottom that if it's children, if it's a pediatric case, they want two exams. What's the story there?
Well, again, there's been certainly there's a lot of possibilities for children and infants to recover from injuries that older people can never recover from. So there's always that concern that maybe the child has something that's survivable. And and the history of the pediatric brain death has always been two examinations and 24 hours apart. And there had been no interest among the pediatric intensivists to change from that. And there really wasn't any data such as there has been from or data or studies that there have been in the adult population that one exam was really good enough. And so that stipulation has continued with the World Brain Death Project to have two examiners for the pediatric group, which I think is very reasonable.
Well, it may be an opportunity for some energetic fellow, to go back and look. And it's like, well, are there any discrepancies? Was there ever someone who was brain dead on the first exam who wasn't brain dead on the second? It's never happened in adults, but in children, maybe it's possible. Is that the concern?
Yeah, so there have been periodically cases of concern or a lot of press about different brain death cases, which are almost always in the pediatric group. And so those are the ones that are particularly concerning. And so having some kind of more research into this is would be great. But in the meantime, the tack that we took for the World Brain Death Project was to be as conservative as possible. So we didn't want to make any mistakes. And to declare someone dead when they were possibly not dead. And so we want to be very conservative. And so keeping that rule of two exams for the pediatric group, I think was very reasonable.
Now, just for American practitioners, is there anything what would you emphasize about these guidelines? What do they need to know that might be different or the same of what they're doing now?
Well, so again, even in the U.S., different states have some different guidelines, and so that's not going to change because there are legal issues. So you'd have to change laws. For instance, where I am in California, we have to have two exams and two different examiners do the brain death exam. So that's the law currently. Now, hopefully, we can maybe change that, but that's the law. As far as differences between the national recommendations from the American Academy of Neurology and the World Brain Death Project, there aren't that many significant differences. We do, in the World Brain Death Project, we do go into much more detail about different aspects of the exam, of ancillary tests, etc. But we don't really conflict very much at all.
Yeah, there's a great table. It's not really a checklist, but it's a table of the, all the things that you should do and make sure you did so that you can confidently say the patient is brain dead. I thought that was very, very helpful. And this paper is in JAMA. It was online in August. I guess the print edition follows a little bit. And it's a wonderful resource. Dr. Sung, I want to thank you very much for sharing your experience in developing these criteria with the World Brain Death Project.
Great. Thank you very much.